Good morning and good evening to everyone. On behalf of the Aesculap Academy Chile, we warmly welcome to you on our first lead broadcast, this time about intensive care unit therapy in times of coronavirus with Professor Marx and Julia, who is the head of marketing involving nutrition healthcare and marketing and B Brown Group. So we are very happy to have you here. And please go to Julia.
Okay, thank you, Paula. Good afternoon and good evening, ladies and gentlemen. I would like to give you a warm welcome on behalf of B Braun Melsungen Global Marketing and Sales. This is our first fully digital event, and my special thanks go to my colleagues from Aesculap Academy in Chile, to Paula and her colleagues, who really supported us a lot to make this event possible. I also would like to thank very much Professor Marx, who is our speaker for today's event. Professor Marx is heading the ICU at the University Hospital in Aachen in Germany, and he has gained huge experience in treating patients with COVID-19. So Professor Marx, it's great to having you here, and the digital stage is yours.
Thank you very much for the kind introduction, Julia. Buenos dias, señoras y señores. Unfortunately, I have to change now to the English language. It's a great pleasure and honor to give you my lecture on ICU therapy in Corona times. On this picture here, you see the University Hospital of Aachen, which is a very western town, very close to the Netherlands and Belgium. In Germany, it's a 1,500 bedded university hospital, and my own ICU comprised out of 100 beds. So in the next couple of minutes, I will give you some information on local and national data, and I will give you some insights into the topic of ventilation in COVID-19 patients, in fluid therapy, nutrition, and in the end, just a few thoughts on special antiviral therapy. Let me start with this information. So just when COVID-19 crisis in Germany started, we managed to publish German recommendations for critically ill patients with COVID-19. This was done with several German societies, and we just translated that from German into English, and you can download that from the PubMed for free if you want to. So the current situation in Germany is in the moment quite stable. We have reached the peak, and our lockdown will be untightened as we speak. And we had so far more than 10,000 ICU treated patients, and about 70% of them were ventilated, intubated and ventilated. And our outcome in the moment is 28%, so it's between 28 and 30%. And what you can see is a registrar where every hospital in Germany who has got an ICU is not only requested, but is obliged to put in the data of COVID-19 patients and the bed capacity. So it's a law now in Germany from our health minister. And you see here that we have in total nearly 20,000 ICU beds, which are now used, and we have 12,000 beds which are free and empty. And this is here between high care, so full-blown ICU beds, and intermediate care beds. And we also have the number of the ECMO systems used and unused. So we know very much indeed what is the situation day by day really in Germany. And you see here the regional distribution, and you can see here the number of the COVID-19 patients. And in the moment today, we have 1,800 patients on ICU. And as I said, the ICU mortality is 28%. This is quite different from other countries and other experience. I just want to share with you the information from the United Kingdom. So here we have the ICNAC report on COVID-19 patients, and this was end of April, this information. And at that time, ICNAC register had about 1,800 patients, COVID-19 patients on ICUs who needed advanced respiratory support. That means non-invasive ventilation, invasive ventilation. And of those, 67.4% died. So we have in different countries quite huge differences in outcome in the treatment of COVID-19 patients, and we can discuss the reasons for that later on. So when we started in the late March, we were in a sort lucky because we had a hotspot very close by where there was a party, so to say, so what we called Fasching. And there was a patient who was infected and was a spreader, so to say. And also we had the reports, especially from North Italy, from Bergamo at the time. And we listened and we learned the lesson and we used the time we had. So we took every step to increase our ICU beds from 96 beds with invasive ventilators to 136. And we prepared even to increase this number here to 205 beds, including respirators, all the equipment required, and also open up units really. And one thing is obviously the machinery. Far more important issue is staff resources. So we doubled senior physicians and junior physicians on the unit. They came, for an example, from anesthesia or from the operating room. We trained nurses from other clinical areas. When patients present, basically very often they have fever and they have a dry cough. And from the first 50 patients, the median age was 65. So they were not so old. So we are not talking only about a very elderly population of more than 80 years old. And nearly all had comorbidities like arterial hypertension or obesity, diabetes, and so on. And as I said, fever and cough are the main, dry cough are the main symptoms, but they not only cough, but they were also dyspneic. So they had the tachypneic and really dyspneic. And this, they were not usually quite, not hysteric or something, quite silent, but severely dyspneic, and some even showed as well gastrointestinal symptoms. Maybe it's a little bit difficult to see, but just to point out two things here. The viral load of these patients we measured, and we detected this most often in a respiratory specimen, but sometimes also in the serum, stool, or urine, was in half of it of medium load. 1/4 was a high load, and 1/4 was only a low viral load in these patients. And only very few had bacterial superinfections. So we only had in 8% of these patients bacterial pathogens. And here's some lab values. Interestingly, they present, here you see the RDS patient in orange and non-RDS in green. They were not with high white cell count. They were not really leukopenic, but rather on the low side with the leukocytes. And interestingly enough, especially those who were severely ill, presented with a very high CRP, C-reactive protein. So this is quite an important parameter. Whereas procalcitonin or interleukin-6 was not particularly helpful in the start, at least to say. Also, which is very important to keep in mind, that the severe ill COVID-19 patients presents, maybe not in the beginning, but in the development of the disease, high D-dimers. They are quite often they developed thrombosis or had pulmonary embolism or other embolisms, and it's worthwhile to think about to anticoagulate these patients to prevent those. So we gave them basically more anticoagulants than our usual protocols in ICU patients. And here is just a picture to see our infection control measurements. So we isolated the patients usually in a room with 2 patients, and our staff used FFP2 masks, obviously gloves and a hat, and gloves and a gown. And so far, really no single member of staff in our institutions, to my knowledge, has been infected through the last now 6 or 7 weeks we treat those patients. But obviously they need to be isolated. And in the beginning, in Germany, in general, we had in some locations problems with the infection control equipment, but in our institution, luckily, we could manage every day that we had enough stuff. Also, what we had to introduce was a new standard operating procedure, that we really treat our patients always the same way. So protection standards I just showed you, also a lab standard and an airway management standard. And what we usually did was only short trials of non-invasive ventilation. And some of patients, I would say maybe 15%, responded to those non-invasive ventilation trials. But if they didn't, we went over to an early intubation and over as well relatively early tracheostomy, because a majority of the intubated patient needed prone positioning, and we had about in a third of our patients ECMO necessary. So why we work more or less, usually we do a lot of non-invasive ventilation, like you see here or here. The problem obviously is, maybe I can skip this here, the problem is with the aerosol. So obviously when a COVID-19 patient has a high viral load and he coughs, then the chance to get that the staff getting infected is fairly high. So we have to keep that in mind, and that means protection of the staff, and also only really non-invasive ventilation if this is really successful. Otherwise, we use then steps to go into mechanical invasive ventilation to treat the moderate or even severe RDS, like we do in other RDS patients as well. Good. The other issue with the non-invasive ventilation we need to keep in mind, and these are data not from COVID-19 patients, but from normal RDS patients, is that quite often when we apply non-invasive ventilation, the tidal volume is higher than 9 mils per kilogram body weight. And you see then here the red survival curve, which is fairly lower than the one with lower as 9 mils per kilogram body weight. And this is very important to keep in mind, that we can also induce harm to the patient by inducing ventilator-induced lung injury using non-invasive ventilation. It's the same as with invasive ventilation. So it's not the good and the bad, but both of them you have to do properly. And here you see the characteristic of our ventilated patients. So half of the 50 hospitalized first patients were ventilated, and 8 were at the time on ECMO therapy. in 17. So 70% had prone positioning, and quite a few had also hemodialysis. So they were really a very critically ill patient who needed a lot of intensive care support. So the question is obviously when to start ECMO therapy in COVID-19 patients, and the relevant question we have to answer is it the gas exchange disorder severe and life-threatening? Is the pathology reversible? This is obviously in an acute viral infection the case. Is the patient able to recover, or in other words, is the patient maybe due to his comorbidities or age or his will not the right person or the right patient for intensive care or even ECMO therapy? And is the applied mechanical ventilation dangerous or inducing harm because we need too high pressures or high tidal volumes? Obviously, in COVID-19 patients, the Extracorporeal Life Support Organization, ESO, recommendation when to use ECMO is more or less the same. So whenever the PO2 FiO2 ratio is less than 150 millimeters of mercury, then we do prone positioning. We personally do not use a neuromuscular blockage very often, but appropriate PEEP according to the PEEP table is highly recommended. We use always, when necessary in these patients, also NO therapy. And obviously when the ratio reduces further or the CO2 is very high, then we have to consider ECMO therapy. And in the COVID-19 patients, we started a little bit earlier. So when the ratio was less than 80, we usually started for thinking about the management. And to better to describe how we did it, I just give you a case example. And here you can see one of our expert nurses. She's really one of our stars. And the patient I want to share with you is a 53-year-old male. So COVID-19 is not a disease of the elderly. We have elderly patients, but many of them were even younger than this patient. He was admitted to our center after being 12 days ventilated mechanically and prone positioning already in a primary care hospital nearby. And the state on admission was he was orally intubated. He was already in multiple organ failure, and his Horowitz index was 48, as you can see here. So, or it was 49. And the CO2, pCO2 was quite high as well with 72.8. And also he was with a high lactate, and the pH was fairly low with 7.25. Here you can see his X-ray, and this is very typical for COVID-19 patients with pulmonary problems. We had many of those patients, and the chest X-ray are nearly identical. So it's really a full-blown RDS like from the ICU book. And here we have the CT scan we performed when a patient was admitted, and you can see also that there was a lot of contusions, infiltrations, and atelectasis, and therefore this patient required veno-venous ECMO. We did in this patient a jugulofemoral approach and with a cardio help. And also we continued prone positioning. We induced lung protective ventilation. He did in the second day, he received a tracheostomy. And ECMO treatment lasted 16 days, and we could wean this patient within 16 hours, which was not too bad. Unfortunately, this patient developed at day 26 a new bacterial pneumonia, and this was quite often when the patients have then a superinfection with bacteria. When we have lost patients, this was quite often multi-organ failure after a bacterial superinfection. He again developed an RDS now to the bacterial pneumonia, and we had to use other systems to help him. It was very difficult to decarboxylate this patient, and we used an ATWAS system for that. Then we could downgrade him to a pumpless system and could wean him again. So here you can see the inflammation values, and this was the first time we started levofloxacin here. And in the second episode, we started meropenem to treat his bacterial pneumonia. And here you see the ATVOS system, and with this, we managed after a couple of days to remove the CO2 successfully, and then we could downgrade this patient to a pumpless extracorporeal lung assist system. And now, yesterday, we could discharge this patient to our weaning unit, and he's now getting better day by day. And are there yet any guidelines so far? Yes, there are guidelines. They're not really evidence-based in COVID-19 patients, but according to our experiences, obviously, we have in RDS for decades, and this is been published from the Society of Critical Care Medicine in the US, as well as the Surviving Sepsis campaign, as well as the European Society of Intensive Care Medicine, and basically similar algorithm we just discussed with when to intubate and when to use ECMO also, and what to do in terms for protection and infection control. Now, I want to continue to the fluid therapy. And this is obviously in RDS patients always a very challenging issue, and especially in these COVID-19 patients, because they had so much interstitial infiltration and edema. And what we have got, as you know, are crystalloids to compensate for extracellular fluid losses, or colloids as a plasma volume replacement. And here's always a discussion because these patients have obviously, on one hand side, not a lot of time to overcome the oxygen deficit, because otherwise they will develop not only lung organ failure, but also multiple organ failure. So we need to be quick to stabilize these patients, to bring them to the organs enough oxygen as well as enough fluids for the circulation. On the other hand, they have obviously this capillary leakage in their vessels, like you can see here from a rat aorta, quite an old picture, but I think still I like these two pictures from a rat aorta 30 minutes after LPS induction. And you can really see the capillary leakage quite nicely. And obviously when you give them fluids, you can imagine where this fluid leaks out as well. And the question is, do we use now only crystalloids or as well colloids? And it might even more harm the patient when these colloids get out of the intravascular interstitium into the interstitium. And there have been quite an interesting study to answer this question. It's still an old, already an old study, but it has been performed quite well from Czech colleagues. It was a randomized study only in 30 patients, but they were in early septic shock with acute lung injury. So quite these patients like COVID-19 patients. And they compared at that time gelatin 4% and starch to 106%. And what they used is the PICO system, and they measured the intravascular volume indices like the intrathoracic blood volume index and also the extravascular lung water. And you can see here when you give starch or gelatin, you can increase in this early phase of the patient the intravascular space, and also you can increase the cardiac index. Hence, you can increase the oxygen delivery, as you can see here. But you do not increase the extravascular lung water, which is an indicator of the capillary leakage in the lung. And it seems like in a certain period of time in the early phase, this is obviously possible. And what we do in our COVID-19 patients, like in this example here, initially we use a combination of gelfusin and sterofundin, both balanced, but we do not go too much into detail into this topic. to stabilize the patient. And you can see here initially we have then high positive fluid balance, but after that it is more on the negative side, because overall we want to be restrictive. So first we use a combination of colloids and crystalloids to stabilize the patient, and afterwards we are restrictive in order to get the situation of the lung and the RDS better. And you can see here that we do not use a lot of fluid the days after, and the patient stabilized quite nicely. So far to the fluid therapy. And now a few words about nutrition in COVID-19 patients. And you see here our ICU team during a ICU round, they are outside the COVID-19 patients' room, and therefore they just needed a mask. But this is then everybody in our hospital wears now one of these masks in order to avoid that the infection can spread out. So what can we do in nutrition in addition to normally enteral or parenteral nutrition? One is the question of vitamin C. And we had this trial, this was a phase 1 safety trial of intravenous vitamin C in patients with severe sepsis. So we have no data on COVID-19 patients, but they are all, the severe ones are obviously also in sepsis. And you see here, in red, the high vitamin C group, and you can see here the procalcitonin and the SOFA score in this group. And also here we had another illustration of thrombomoduline and CRP. And all these patients with acute lung injury was included in the study very early, within 48 hours of the RDS development. And very interestingly, majority of this predefined outcomes were not different between these two groups, but there's always a famous but in studies. This but was, we had a significant increase in ICU and hospital-free days and a significant reduction in mortality. Obviously, this was only a small trial, but it seems like giving ARDS patients vitamin C is not harmful and maybe even helpful. Another option is supplementation of zinc. And this is especially interesting in virus infections and in coronavirus infections. Why? Because zinc inhibits coronavirus and the arteriovirus RNA polymerase activity in vitro, and also the zinc ionophores block the replication of these viruses, at least in a cell culture. Obviously, this is not evidence-based medicine. This is more common sense due to experimental lab results. But the ESPEN just published in March this year an expert statement and practical guidance for nutrition management of COVID-19 patients. And they said, in general, low levels of intakes of micronutrients such as vitamin A, E, B6, B12, zinc, and selenium have been associated with adverse clinical outcomes during viral infection. This notion has been confirmed in a recent review, and therefore they propose to give vitamin C or even omega-3 fatty acids, as well as selenium, zinc, and iron, at least should be considered. And they suggested that we should, as ICU specialists, provision of daily allowance for vitamins and trace elements. And what we do in a daily clinical practice in our institution is we give 6 grams of vitamin C and 4 times 6 milligrams of zinc to our COVID-19 patients. So to come to our end, just a few words about special antiviral therapy. And there's a nice review published in the JAMA, published online last month in April, about different possibilities how to treat SARS-CoV-2 virus with potential drugs, or about the targets of drugs. And I just want to give some information about the remdesivir. We treated those as compassionate use in a couple of patients in our institution as well. And we have very interesting results about this drug. This is being published from a Chinese investigation in the Lancet in end of April. And in the Chinese study, there were around 250 patients in the control group compared to remdesivir. And you see here the viral load between the two groups. And there's basically no difference between the two groups. And also the improvement rate of the patients were absolutely comparable and not statistical significant differently. So the basically it was without any effect if they have used remdesivir to treat COVID-19, so severe COVID-19 patients, and it was not associated with statistical significant clinical benefits either. On the other hand, we have this American approach. They started the NIH clinical trial. They did an so-called adaptive randomized control trial with remdesivir, and the primary endpoint was time to recovery. They started in February. Obviously, the coronavirus disease started in the States later than in China. They had so far 1,000 patients in 68 centers, and in the interims analysis, which was already publicly pronounced very effectively, I would say, then so the time to recovery was using remdesivir was reduced by 4 days, so 11 days against 15 days, which was highly significant. And also the mortality was different, not statistically significant, with a p-value of 0.059, but it was 8% compared to 11.6%. Although it has to be said, it is interesting that there was already this interim analysis and this went already public. This is unusual, but maybe in crisis times, this is possible. I don't know. We can happy to discuss it with you, how to feel about it. And obviously, then it was published on the NIH website, and maybe you've seen it on the television. There was the FDA head and the head of the company as well, with President Trump, and basically announcing this result. So to close up, here I just want to share with you how to treat COVID-19 patients. So when they have just only mild RDS, we should use protective ventilation with a pressure less than 30 centimeters of water. Obviously, we should see whether they have additional bacterial infection. We should aim for a saturation between 92 and 96, and conservative fluid strategy. And only when they have bacterial infection, then we should consider antibiotics, because otherwise we just induce resistance, I would say. And we do not give corticosteroids to our patients. If they have moderate to severe RDS, then we should apply higher PEEP. Some use neuromuscular blocking agents. We basically don't do it because we sedate our patients properly to facilitate ventilation targets. And if they are PEEP responsive, we use recruitment maneuvers. Quite often we need prone ventilation. We do always 16 hours in our patients. It works really well. And still, we personally, we do not use corticosteroids, and we do not use the antivirals either on a regular base. When they deteriorate further, we really use a trial of nitric oxide and rather use early ECMO therapy in our patients than late. And we have to prepare to treat them very long. We have patients which we treated, or on average, we treat our patients 23 days on mechanical ventilation and or ECMO. And with that, I thank you very much for your kind interest, and I hope that I could bring you some informations which are useful for you, and I'm more than happy to take questions. Thank you very much for your attention.
And I have a question. Could you say just a few words on clinical nutrition?
Yes, basically we use the same the same nutrition as in other ICU patients. So we try to give enteral feed, but it has to be said that in those patients, especially when they have prone positioning, quite often they need, at least in addition, a parenteral nutrition, and we use just our standard nutrition here, so nothing special. I know that there's discussion that you need special lipid and so on in RDS patients, but we haven't seen any real evidence for that. I think the most important point is really that you check that the patients receive enough nutrition. Quite often, if we give enteral and they this is not all, everything is then well received, but it comes back through the nasogastric tube, then they receive not enough calories, and then therefore we have to supplement at least via parenteral nutrition. And the data nowadays that enteral nutrition is so much better than parenteral is maybe not even true. And what is definitely true, that critically ill patients need sufficient calories.
Okay, Professor Marx, thank you so much. This is very interesting. We have a lot of people saying things to you that is very helpful to hear you. And Julie, I think you have the last question, I guess.
Yes, I have another question, and we heard that many other hospitals stopped their elective surgeries and postponed it to a later point of time. But I mean, Aachen is a big university hospital. Is there the normal routine around COVID, or is there any change in the daily work for the other departments as well?
No, we stopped elective surgery. We only did, let's say, emergency or very, let's say, our tumor patients, for an example, or so. We try to do all our surgical work and patients are really in need or even in emergency need for operations. So we reduced the number of ICU admissions, I would say, by maybe 1/3, because obviously we have a lot of tumor patients as well. But there were, so in all over Germany, and this was also recommended from our Ministry of Health, is really to stop elective surgery. And we are just beginning of this week, we slowly going back to, let's say, normal workload, and we have to reorganize everything. Although it has to be said, this is now for us quite difficult because we have still 25 COVID-19 patients, and we are also obliged from our government to keep our capacity by 25% of our ICU beds ready for new COVID-19 patients. And we do not know now it's really impossible to predict how many patients will now be infected as we stopped our lockdown now. Do we have a second wave? How high the second wave will be? Will it be happen at all? And so far we have to be just ready to for these patients, and hopefully we do not need our resources for them.
Okay, Thank you. Okay, the next question is, Professor, what is your position regarding prophylactic anticoagulation and formal anticoagulation?
Yeah, we had really experienced in our first COVID-19 patients pulmonary embolism sometimes, and the advice is to give, for example, heparin or up to a PTT between 50 and 60 seconds, and this is what we did. So we try to be so this is more than prophylactic. This is really therapeutic anticoagulation. What we do not do usually in our ICU patients, usually we are between 40, 45, 50. But in those patients, we were above 50, and we checked also for antithrombin levels in order to prevent pulmonary embolism and other embolisms in these patients.
Thank you very much. Probably one last question. There is a big discussion about the personal protective equipment, or rather the lack of it, that there is not enough. How often does your staff change the whole equipment, as you showed us in the lecture?
Well, whenever they enter the room or get out of the room, and I would say because it's quite warm when you use all this protection equipment, usually they are maybe in the room 15, 20 minutes or so, and then they get out and get changed again.
Okay.
So quite often, so our usage of masks and gowns and everything is quite high. And maybe you've seen on the pictures, in some of the pictures we had gowns which were just one way, and others reusable. So we had really at one stage problems to get enough single-use gowns, and we used again our reusable ones, which we have stopped for years now, but we still had them, luckily. And in the end of March, we had also problems to get a sufficient number of masks. Our administration did really a very good work at the time, but it was not easy and really expensive to buy enough in. But as China has started to produce again, this is not a problem anymore, at least in our country.
Honestly, thank you so much, Professor Marks.
My pleasure.
It is really an honor to hear you and to learn